He believes in his work. So when you hear him speak, and certainly like today, as he speaks about overlooked but potentially dangerous signs of GI malignancy and what should be done, at the end of it all, you would nod and say, he know what he's talking about. Let's welcome Dr. Sahle Griffith.
Okay, good afternoon. While I come up here, I wanted to acknowledge the presence of a certain individual. They say that we stand on the shoulders of giants, and so at this point, I want to acknowledge Dame Selma Jackman. That is one of my surgical mentors. That to this day, if I do open surgery and do adhesive lysis, I feel good if my fingers moving like Miss Chapman knowing. Thank you. So, this talk today, really and truly, I was a little curious as to the audience. It seems there was a mixed audience, and mixed audiences always pose challenges to surgeons because surgeons bore even non-surgical audiences. That's the truth, because we get very technical. What this talk, I hope, is able to transfer, and I wanted to gear it towards the persons here who are outside of the medical field, but also to act as a reminder to some of my colleagues. Because in reality, what we see sometimes on the surgical side are persons who are having complaints about something that could possibly be innocuous. And by the time it becomes obvious that it is serious, it is already a little far down the road. And I've come up with a little, let's say, a couple things that I noticed that we should probably look at a little differently if they're occurring with ourselves. So this mouthful of a presentation barely means if we see something that we're wondering about, this is an important one to check it out. That's probably the easiest way to go about this presentation. I have never used this before, but great. So the only thing I wanted to talk about there was the Caribbean Colon Cancer Initiative. Now, I am by training an MIS bariatric surgeon, so I went away and did a fellowship in advanced MIS and bariatrics at the University of Alberta. During that time, we did about 150 bariatric cases, but the others were a scattering of things. Yes, outside of endoscopies, we had to go over 150 of those, but the colons and so were there. We did about 60 colons that year. When I came back here, and I thought I would be a bariatric surgeon mostly, because there is a problem with weight, and so here BMI, as we heard earlier. But it turned out that I became some kind of colorectal surgeon, and I say this because what happened was when we look across our patient listing, colorectal cancers are the most common things outside of gallbladders that we address. Gallbladders, appendix, colorectal cancer. We looked at our team's data from the QEH, May, June, July of this year, and there were 42 colon resections we did in 3 months. In reality, if you look at the data that we have about colon cancer over maybe the first, I think it's 7 or 8 years, Dr. Haynes got to tell me, of our practice, we were doing around 30 colon cancers a year. Why is that interesting is that Barbados has an incidence of colon cancer of 30.8 per 100,000. So that'd be at a $300,000 population, that's about what? A third? And so it began to astound me that we didn't really have any clear data about colon cancer in our environment. And I promise that I'm not going to take too long. I just need to digress because I really want to bring attention to the Colon Cancer Initiative. We partnered with persons, and in partnering with individuals, we end up partnering with universities in the USA, in Canada, and in Nigeria. And we have clearly partnerships across UWI here and regional partnerships. Because colon cancer and GI cancers in general are not well studied amongst our populations. And just like the prostatic carcinoma, it is a real scourge with regards to the non-communicable diseases. So I am putting it out there that we're going to have some stuff coming down the pipelines looking at epidemiology that we're working alongside the Dalhousie group with, stuff with genetics. And I would like that there is support for the colon cancer initiatives, the health promotion team. You would see Nurse Sargent and Dr. Haynes in the back. But they have been working extremely hard, and I really got to give them some credit on that score. So, across this presentation, we're going to just look at a couple things. I'm not going to list all of the things that could possibly be related to a GI cancer. I'm going to list them, but just to say, hey, this list exists. But we're going to look at the things that would prompt me to think about a gastroesophageal, really, and things that would prompt me to look at colonic, because we must remember that Barbados has the 8th highest colon cancer incidence in the world. And we have the 2nd worst survival in the PAHO region. Yeah, it's ridiculous, yeah. So, the GI tract. The GI tract is the tract that starts in the mouth and ends in the anus, pretty much. It's rather long. There are a number of outpouchings, so the liver, the pancreas, and so are related to it. But generally, when you're thinking about the GI tract, outside of the, as I said, liver and pancreas, we're really looking at the esophagus, the stomach, small bowel, and the large bowel. The large bowel being the colon and the rectum. So, that busy-looking scene, I realize you don't even have to look over there. That busy-looking scene really is all of the things that could potentially be pointing to some kind of issue in your GI tract. And it's quite extensive. So realistically, there's some of them that jump out. There's some that might jump out at the general practitioner group. There's some that jump out at me. And so I wanted to just discuss the ones that jump out at me. This little group, dyspepsia, heartburn, right? Heartburn, common garden variety heartburn. Anemia, that's low blood counts, feeling tired, feeling weak. Often associated with fatigue. Weight loss. But those group there, anemia, fatigue, and weight loss, I don't really want to see a patient coming with any of those. Not really. In fact, we're going to discuss screening because I really would like to see, like Dr. Kai said earlier, much more screening. But at this point, I don't want to see those. Those are pretty advanced. So abdominal pain, constipation, or diarrhea, we call that change in bowel habit, rectal bleeding, and rectal pain. I would take rectal pain from the mix because oftentimes that is a little more spurious. But abdominal pain, constipation, or diarrhea, rectal bleeding. Those are the things that most concern me. So, red flags for gastroesophageal problems, and I put only one. And I put this because one of the things that we notice is a number of patients having prolonged histories of reflux. I got heartburn. I have reflux disease. So the patient for a number of years is taking PPIs. That's good, no problem. Unfortunately, there are a subgroup of persons with this recurrent heartburn who end up having significant gastric cancers. And to be honest with you, gastric cancers are one of the cancers that I fear because they're only divided into 2 groups, early and late. And what distinguishes between early and late is if it has grown into the actual just lining of the stomach. So early disease hasn't gone past the lining, late disease has gone past the lining. And the survival difference between early and late is profound. So in reality, I wanted to discuss for a minute recurrent heartburn. This very busy slide here is really the guidelines for the American College of Gastroenterology, and it's divided up into, to basically say, if you've had heartburn for a while, you should be checked for H. pylori. H. pylori is a little bacteria in your stomach that causes ulcer disease, but it also can increase your risk for gastric carcinoma. the test for H. pylori is a stool test. Yeah, you do H. pylori stool antigen. If it's positive, you got H. pylori. Yeah? At that point, you can treat the H. pylori and retest. If that treatment and retest has covered the problem, great. If the heartburn persists, this person should get a scope. So I put down the algorithm there. Simple, easy algorithm. This is a complicated slide. If you have heartburn for a while, your doctor should have sent you for a stool test looking for the presence of H. pylori. If they were present, you should be treated for it. You should then be retested to see if it was cleared or not. If it was not cleared, then you have to go to secondary lines. But if it was cleared and your symptoms have gone away, we could continue to watch you. Should your symptoms persist, you should have a scope. If you are negative for H. pylori with recurrent heartburn, you should have a scope. That's pretty much simple and to the point. And I mention this because oftentimes gastric carcinoma in our environment is not so common, but almost always these people have been complaining of heartburn being treated with some kind of acid-lowering drug or something for years, yes, without investigation. Colorectal carcinoma. Yes, and this is heavier than my usual talks at the Cancer Support Services, and it's heavier only because I want that we pay attention to these issues, and we spread it to those persons who are in our circles. Yeah. So the scope of the problem locally, I want to do a little discourse on this. It's not too long. If you look at this is the data, and it's small. The writing is pretty small. But if you look at this is the data from the 2008 BNR that looked at the fatality of cancers in Barbados according to type over the period of time of the study. And if you see the highest incidence of mortality in 5 years was colorectal cancer. And there's a paper done by Griffith et al., I think published in 2021, looking at this particular matter, and what we found was that 64% of the persons who presented had advanced disease at diagnosis at stage 3 or 4. 64% were 3 or 4. And 41% of the advanced disease of that 64% were stage 4, an advanced stage 4. So, incurable disease. And I say that because stage 4 represents disease that has spread from the bowel to another site. And as you heard, so far, thank God, Antoine had similar disease. He had stage 4. He was treated. He was offered a curative therapy. And 6 years later, he's here, which means that, yes, that is curative. However, a significant portion of the persons who present with stage 4 do not present as early in stage 4 as that. Could you imagine me talking about as early in stage 4? And I contrasting this to my experiences in Canada. And in Canada, people presented with far earlier disease. And Canada does not have the highest screening in the world. I think so far, even the US, because of the insurance plans, they screen over 50%. I think it's 52%. I can be corrected. Canada is screening about 40-something%. We are doing what is called, I don't know what we will call it. It's more diagnostic than screening. So we ended up with more disease that's very advanced. Now, if you look at this particular pie chart here, around half of the people in this group were either between the ages of 50 and 70. So relatively young persons. So around 50% of the people were coming, and the majority of those had advanced disease. Now, I cut back to the things that concern me. And I only went to this other thing to just to outline not only the scope, but allow that there is, or allow a discussion to unfold, that there is the opportunity for us to be able to identify, even if we don't identify at screening, but to identify what might be a problem early. So, I'm moving from the least relevant to the most relevant. I start with the constipation and diarrhea, change in bowel habit. So, change in bowel habit is the least predictive. And I say this because if you are diabetic and you take metformin, you could get diarrhea. unrelated to bowel issues. If you have, let's say your outside is very hot now, you're not drinking as you should, the amount of water, the colon itself helps to preserve water in the body, so you could get harder stools and hence have a constipation. So realistically, whilst constipation and diarrhea can be a harbinger of problems, it is not the most accurate. But it is one of the ones that concerns the patients the most. So when you have constipation, you come and say, hey, I need to have something done. But if you weren't having constipation, you might not, yes? But constipation doesn't necessarily point to yes, as a single symptom. In a constellation with other things, it's one of the most disturbing of the symptoms in my mind. Rectal bleeding, the PR bleed. Now that's a disgusting image. I'll be honest with you. Yeah. People bring those to me all the time. I'll be honest with you. Yeah. So, rectal bleeding as a symptom. It is alarming. Almost always, if you have significant rectal bleeding, the person is going to come to the doctor the next day and say, hey, there's something really wrong with me. Yes? It is one of the things that it is important never to underestimate. So, in persons aged 40 and over, this is data from 1995, so this is a long time it has been known. If you're age 40 or over, and you have a bleed, even in the presence of hemorrhoids, you have a 20% chance of having something else. Something else. You have a 1.7% chance of having a malignancy. Now, this rises with age and it rises with other things, and if you have a sequelae of symptoms, this is worse, but as an individual symptom, this is the discussion. But pretty much, you don't bleed like that, like this person has bled in this toilet, and you don't come to the doctor. It's few do it, normally it's men, and they normally say they're going to watch it and see. Unless the wife notices it, and then they bring them immediately, you know. So, hemorrhoids, that's the most common one. As I said, hemorrhoids alone should not, if you have hemorrhoids and you're bleeding, you can't assume it's the hemorrhoids once you're over 40. It's not a safe assumption. Anemia. No, anemia is a big one because oftentimes anemia is only identified late. So if you aren't going to the doctor and you're losing blood slowly, the capacity, the reserve that the human body has is great. So you could well drop your hemoglobin levels down to about half, so down to about 6 or 7, and still be walking around normally and saying, boy, I'm just feeling tired. Yeah, I don't know, I'm tired all the time. And I'm sleeping and so forth. If you weren't going to the doctor wouldn't pick it up. What is often surprising to me is the number of times that persons, especially females, and it's because, as it was discussed earlier, the menses and so on, the role of menses in dropping your blood counts. But oftentimes, persons who are in the latter part of their, let's say, reproductive years or after menopause come with anemia and they're not thoroughly investigated for the same. I personally believe that if you are a 40-year-old in this country, and I have reasons to say this based upon the same national registry data, but one would argue maybe 45 if you use more international figures. If you are 45 and you have anemia, male or female, you should be scoped top and bottom. That's my particular position on the matter, because there's something going on with you. Abdominal pain. So abdominal pain as a single symptom has been found to predict in males over the age of 70 the existence of a colon cancer, or the relationship is about 4 times normal that of the baseline population. Abdominal pain is a single symptom. Combined with any of the other symptoms is pretty much pathognomonic. Now, the nature of the pain is something that I have been studying via anecdotal pursuits. I've been asking people about this pain because I always wonder how people come with late disease saying they never had a symptom. You never had a symptom? Yes? And I realized, yeah, again, as I said, the human body has a great reserve, so you could drop that blood count to 8 and you wouldn't recognize it until after you have other symptoms. But the one symptom that I have come to notice exists long before any other symptom is a cramping abdominal pain around the time you have to pass stool. And what I mean by this is we have all had cramping abdominal pain around the time we had to pass stool. If you had a bad case of, you eat some food that's not so hot, you've had cramping abdominal pain around the time you had to pass stool. But what I have noticed is these persons pretty much every time, and it's been going on a while, have had some kind of low-grade pain for months that is getting progressively worse around the time they have to pass stool. And that little caveat interests me a lot. If I hear that, I believe you have a problem. Now, what to do here? So, because the cramping abdominal pain or abdominal pain in general, and that study really spoke to the presence of intra-abdominal carcinomas, could be caused by a number of things, the same pancreatic cancers, renal cancers. We were talking about prostate earlier. It depends on the location of the pain. But given that colorectal cancer is so common in our environment, what should we do if we are having abdominal pain? I think that once you've passed the age of 45, you should have a FIT test. And a FIT test is a screening test. It's a screening test for cancer, for colorectal cancer. And in reality, yes, one would argue you don't use screening tests in the presence of hard symptoms. But realistically, if you're talking about the environments where the government may not be able to offer the full extent in a timely fashion of the care to the entire population at any one time, and persons are seeking to do private care, I think that the FIT test allows for the very basic to exclude a colorectal cancer. If you're FIT test positive, then at that point you need a colonoscopy. If you're FIT test negative, then at that point it could be considered you need a CT scan. Because any symptom where the individual symptom itself, especially as I said, males were more related to males than females, and it increased in significance with increasing age. But by the time you reach age 70 and you're having abdominal pain as a single symptom, your risk for an intra-abdominal cancer was increased by, or at least for the presence of there to be an intra-abdominal cancer was increased 4 times over normal. So I'm thinking in that context, yes, it's best to do the FIT test. So what is the FIT test? And I hope that this is, I know what happened there. David, you can help me? I'm unable to advance. Anyhow, so I wanted to talk about, that's the next one, screening. Because in reality, none of these things do we want to be seeing, especially in a country where, as I said to you before, we have one of the highest incidences of colorectal cancer in the world. And it's interesting to me, and I'm going to mention this one because this is kind of hot off the presses. So we recently signed an MOU with the African Research Group for Oncology. They're based in Nigeria, and it's in large part related to the fact that a significant proportion of Barbadians are of Nigerian descent. In fact, I traveled to Africa, and I've been to Senegal, and when I go to Senegal, I see a number of people that I think I know. Yeah, but normally it's be Jamaican people, so I believe that more Jamaicans were in Senegalese will end up in Jamaica. But when I was on the flight going to Nigeria, and people started to get on the plane, I was saying to myself, but boy, this looks like Barbados. It has literally Nigerians look very much like Barbadians. However, so when they looked at the genetics of the colon cancer, and one of the things that interested me is that the catchment hospital we were at, which was the lead hospital working with this project, they had a catchment of 600,000 people. And when we were speaking to the surgeons there, they were seeing 4 colon cancer cases a month. I just said, in 3 months, yes, we had 42 patients. That's 14 patients a month. They looked at the MSI genes in the Nigerian population, and MSI was 3 times higher it was expressed about 34% of the times in cancers in that environment, as opposed to 11% in most of the other international studies. But we are not seeing that here. So we really don't know. One of the things that interests me is the role of diet, because there's a lot of processed meats eaten in Barbados, and processed meats are one of the most significant, let's say, cancer-promoting factors with regards to colorectal cancer. And so whilst the minister spoke about alcohol, maybe we have to make an assault on ham and bacon. But that would require some kind of epidemiological study, and that's something that we, as I said, we need to look at. We need to look at the diet, and we are soon going to be bringing out some things, asking persons to participate. But in reality, screening is what we need to do. Why screen? Because screening has been shown to reduce mortality in almost between 20-something, I think it is, 20 and 68%. Significantly, because we are finding earlier stage disease. Colon cancer at stage 1 has an 80% survival rate, 80 plus, 80, closer to 90s to be honest, with surgery alone. Just as Dr. Case was speaking about with the prostate. Finding these things early is far easier than finding them late. All of them begin as benign polyps. Now, some people have polyposis syndromes. We're not seeing too much of that here. I have a couple of patients that have had it. Those persons, if you have so many polyps, at that point we have to counsel them specially. But those are not average risk individuals. So we're speaking about most of the general population here, average risk. Average risk people, they should be screened, and they can be screened depending upon the system, and I wanted to discuss that. Screening depends on how you see it. In my environment, 45, because we have a predominantly Afrocentric population. One would argue, based upon stuff out of the BNR, and they're identifying ladies presenting, because the ladies always do better with any kind of screening than men. But the ladies were presenting at age 45. They had a peak at age 45, so maybe we need to start the screen at a little earlier than that. Should stop at age 75 unless you are fit and healthy, and at that point you can continue to screen because your life expectancy would allow for it. And the interval depends on the modality, so I didn't want to get into that too much. But the basic modalities here, yes. For me, fit testing is cheap, it's easy to do. There is a study in the Lancet coming out of the same group that we are working with, where they found that their fit tests, their false positive rates were slightly higher. But having scoped people in Nigeria, I know that they have a lot of hemorrhoids in Nigeria compared to here. It's ironic. You would think that there is a lot of ground provisions, but their fruit and vegetable intake is a little bit down. But in reality, the situation for us is we could do fit DNA. Problem with that is cost is about $1,000 a kit. And so ultimately, yeah, 500 US to land it here. So ultimately, if you're talking about a fit test is 100 Barbados roughly to get done. So it's 10 times cheaper to do fit testing. And the benefit of fit DNA relative to cost is still something that can be debated. Flexible sigmoidoscopy every 5 years, I don't really like that one, to be honest with you. Yearly fit and sigmoidoscopy every 10 years. Now, that's an accepted guideline, but for us, we are finding an instance of right-sided disease. So sigmoidoscopy looks at things, the rectum and the colon on the left side. We are seeing an instance of right-sided disease that would suggest that we should offer the colonoscopy at 10 years to most persons, but given costs, given the fact that we have to have skilled practitioners to be able to do this, fit testing followed up by screening colonoscopy for positive tests would be an acceptable alternative in my mind. As you can see there, all of the positive modalities should be followed up with colonoscopy because that's the gold standard. It allows for disease prevention as well as disease identification. So, thanks everybody. There are a number of references. Yeah. All right. Any questions here? I'm good. Where can you have a fit test done? Well, I think you've answered a question that Esther can answer. Esther, maybe you could get Esther, Mike.
Hi, good morning or afternoon. Well, I am Nurse Sergeant. I'm the Health Promotion Nurse for the Caribbean Colon Cancer Initiative, and you can actually reach out to us, and you can have that test done. We're also with some general practitioners, and hopefully, Cancer Support Services will be coming on board to help make the distribution of these fit tests more available, but you can reach out to us, and before you leave, I can give you our contact number, or if you want it now, it's 832-5756, and you can reach myself or Dr. Haynes at that number, 832-5756.
Okay, I'm not causing trouble now. One is actually a commendation and one is actually a comment I'm asking about. But the first commendation is this. Many people at the level of expertise of Dr. Sahle leave Barbados and go abroad because they can be paid more. Dr. Sahle has stayed and is passionate and we in Barbados are so grateful for that. So thank you.
Thanks for that.
Okay. So the comment is colon cancer is preventable with early screening. And I didn't hear you emphasize that. So can you comment on that, please?
Yeah. All right. So that's actually a valid point. So there are, and I don't like to get into too much discussion about screening, because the screening, there are a lot of, for, let's say, in the surgical circles, we have had a whole lot of back and forth about different types of screening. But it cannot be questioned that colon cancer is preventable, and one can do with removal of polyps, cancer prevention as a part of the process. So in reality, the fit testing is to be able to cheaply search a wide section of the population for risk factors for at least the presence of a colon cancer or an advanced polyp. And then the colonoscopy allows for its removal. So if it is not a malignancy already, it's just a polyp, realistically removing that has prevented colon cancer. The other things where this has been found to be true would be cervical cancer. And so I have been doing this particular medicine for 24 plus years. And early, when I was a junior, cervical cancer was not only ubiquitous, but it was always advanced stage disease. I was in Jamaica, and it was, to be honest, very depressing for me. Nowadays, you rarely hear about people having advanced cervical cancers because of the presence of, let's say, widespread pap smears and colposcopy and so forth. And if it could be done for cervical cancer in our environment, it could certainly be done for colonic cancers. But it is not as sexy. So I'm gonna touch on something that we kind of were playing around with before. In a few days, I'm gonna be 50 years old. And I don't celebrate, I don't know. So, realistically, why I say this is, when they were having the talk about the prostate, this was ringing in my ears, yes? Because I have not been, like many of my medical colleagues, as judicious with my screening as I should be. I have done it at age, I think, 45, and I did it at 40. But I haven't been judicious. So I was there thinking about it and saying, boy, you know, I really need to get my PSAs done. Yeah? And I thought about, why would I be thinking about it? And the next thing I thought about, something that maybe y'all didn't think about, I thought about nerves. Yes? So I literally was thinking of getting up, but there were so many questions and asking, what would make one choose to have a radical prostatectomy now versus radiation? Because if you can get linear accelerated results that are similar, you would maintain your sexual function much more aggressively. Yeah, so this is where surgeons' minds go when other people are, having other conversations, be thinking about if we can still function. And I thought to myself, that's sexy. It's a thing that I would want to know early because I don't want to have to go through, wearing a catheter and all those kind of things, yeah? Similarly, breasts. So breast is sexy. Breast is what makes a lady feminine, etc. Yeah? Same thing with cervix. You know what I mean? You think of it as nobody don't find colon sexy. So it'd be hard to sell. It'd be hard to sell this fit testing because people always think, boy, they don't be thinking about that. But I draw your mind back to the fatality rates. And if you look at those fatality rates, colon cancer is killing far too many people in Barbados. So the BNR had other data that within 3 years, 65% of the persons who are diagnosed with colon cancer have passed. And this is a preventable disease. So if we find this early and we remove these polyps, we could stop people from having colon cancer. As we could reduce the incidence of cervical, we can reduce colon. Yeah? And it's one of the few where that can actually be done. So, yeah.
Yes.
Sorry. Quick question, really quick. Thanks, Dr. Griffith, for an excellent presentation. I just wanted to find out, you mentioned the H. pylori testing on stool. Is it equivalent in effect to the H. pylori testing on blood, which is offered by one of the labs?
But both of them, they offer both. So the stool is an antigen test, so it's testing for the presence of the bacteria, or at least the antigenic portions of the bacteria. Whereas the blood test is an antibody test, so it's testing to whether you have been infected and recovered it. You know what I mean? So whether you have antibodies present. So one could have antibodies present, as you would well know, and you had already cleared the infection. So the better test to do in the context of let's say, trying to find out if you have H. pylori organisms in your stomach, if you're not going to be the least invasive test, I should say, because there's flow testing, there's actually looking for the organisms on the microscope. But the least invasive test that would allow that information is the stool antigen.
Okay. Just want to make this quick point. Just want you to clarify something for me.
No problem, sir.
And I must thank you for your matter of fact, the delivery, very good. Appreciate it greatly.
Thank you.
For years I've been hearing that, and I think I saw it mentioned in the list of red flags that you had in your delivery, that the interval between colonoscopy should be 10 years. But some years ago, I was part of a particular study where this American professor said that if polyps are found, it should not remain at 10 years. You should have an earlier thing. I want you to clarify that because I never heard that.
Okay. So, all right. In this particular scenario, we were speaking of persons of average risk and I should probably maybe make the caveat, whose colonoscopy revealed no polyps, right? One could go so far, so there was a discussion earlier about NCCN guidelines, right? So NCCN is the National Comprehensive Cancer Network, if I remember correctly. That's the acronym. And their guidelines, they list a number of guidelines, and it's very helpful to anybody managing cancer and surrounding screening, etc. And there are different types of polyps that you can find. So the group that concerns us most, to narrow it down, would be something called adenomatous polyps, polyps that form adenomas, and these go on to form cancers. There can be hyperplastic polyps, and there are other syndromic groups associated with that, but realistically, the adenomas, those are the polyps that concern us. It depends on what kind of polyp you find. So if I find a singular polyp that's less than a centimeter and is low grade, I could choose to say, okay, we will watch this person at a 10-year because that's not so significant. If I find a single polyp that's over a centimeter and has changed certain types of changes, that particular polyp is a more high-risk polyp, and so at that point, the movement, it changes. So if it is 2 centimeters with high-grade dysplasia, you should have a repeat scope within a year. If you find 3 polyps of whatever size, all adenomatous, so all of them adenomas. So let's keep them, that's the group that we're thinking about. If you find 3 polyps or more, you should have a repeat scope in 1 to 3 years. Yeah, some people say 2, depends on the type and depends on the grade, right? So if they're all low grade even, you'd 1 to 3 years. So realistically, the caveat on the screening guideline should be for the person who is of average risk or who no polyps were visualized or no significant polyps were visualized at the colonoscopy. I should also mention high-risk people. So high-risk people, if you have a number of persons in your family who have had colon cancer, so first generation, 2 first-generation relatives, and maybe a second-generation relative, something like that, you no longer fall into that category of people that can have screening once every 10 years. Some of those persons is once every 5. If you have certain genetic abnormalities, they should be once every year, once every 2 years, and some of them we should have a discussion about removing your colon, depending upon how many polyps are there and all that kind of stuff. But the general caveat with screening is that we're speaking to the average risk population in whom there was a normal screening study.
All right, we have a question over here. And also for our online participants, if you have a question, you can just turn your mic on and your camera, sorry, and make your presentation.
Yes, Dr. Griffith. I had a colonoscopy done earlier this year, and it was good. There were no polyps found. And the doctor told me that I don't need to get another one, only if something come up. But I also have hemorrhoids. So in the case like that, what happens?
Yes, so that's always a little interesting, because when you have hemorrhoids, you can bleed, and when you bleed, you might get nervous. And if, yeah, I know I've had a couple of patients like that. Realistically, I'm assuming, and I do not know, but I'm assuming that he's suggesting this based upon your age?
Yes, I'm 70 now.
Right. So what he's thinking is, okay, for a person who has had a normal scope at age 70, who is of average risk, so you're falling into that group, the next screen for you would be in 10 years, at which point you would be over the age of 75. So if you are a fit 80-year-old and you're feeling good, you can choose to say to him, I would like to get a screen. But realistically, the screening ends at 75 for, let's just say, for most persons, because one is looking at the life expectancies of the individuals relative to their age at the time of the screening. Yeah? I think the hemorrhoids discussion. So, as we mentioned, the bleeding. So we know that bleeding can exist, and bleeding is a risk factor for other things. However, I also mentioned that any of those scenarios is modified by the number of symptoms that you have. So if you're known to have hemorrhoids, you also had a clear scope earlier this year. If you were to bleed next year, it might be considered as highly likely related to your hemorrhoids. Yes? I don't know if you have diverticular disease or anything else, so I'm just going to say it was normal aside from hemorrhoids. At that point in time, there will be no need to rescope you really if you have no other symptom. If, however, and I'm choosing 5 years as well, because realistically the discussion about it taking 10 years to become, to move from a polyp to a carcinoma can be modified by various things. Yes? So in reality, if at 5 years from now, you are having bleeding, but you're also having a change in bowel habit, and you're having abdominal pain, at that point, I would no longer be comfortable saying, hey, I had a scope 5 years ago. I would go to my doctor and have a discussion that might involve him choosing to look again. Yeah?
Okay, thank you.
No problem, ma'am. All right. Thank you, everybody. Have a nice day.